cases and real situations you can get. Multimedia integration, interactive decision-making pathways. You can give instant path and what is called as a performance analytics. I think this is something is the most important aspect of all this digitization, and customized scenarios for various specialties. Now, technology supporting this, I'm sure VR and AR we talked about, web-based and mobile platforms are becoming very popular today. As I said, it is cheaper today. I think as I said, Indian company has already come out with the VR and they are already launching it. But I personally feel over next 2-3 years, all this will be easily available and we will be able to use these technologies, not very remote, telementoring, telesimulation. These are not going to remain words which are only on paper. They are going to be there already. Web-based and mobile platforms are used now more and more. And most important is now all these need to be integrated with your LMS. Whatever LMS you are using, I think we need to integrate this. And there are many universities, Now, to be very frank, I work for Tata Institute of Social Science. And whenever I get assignments or projects from them, they already have got plagiarism check for AI similarity. And this is becoming very common today. So LMS will check it for me. It will find out which areas are copied from AI, which areas are copying from internet, and it will give me complete thing before even I start analyzing that particular case. So there are challenges of using virtual patients. There are technological barriers. I find many people still not be able to work on these mobiles and laptops effectively. High cost and maintenance. We must really understand in our country, high cost is always there. But today, I think things have become a little cheaper. For example, making PowerPoints. You remember? Now, AI PowerPoint gives you at 83 rupees per month. And as many you want to do it. So now these are becoming cheaper, affordable to all of us. Teachers' resistance. That is the major problem we are going to face with all this. The maximum resistance comes from teachers, not from the students. Students are ready to accept. I'm sure half of the students have already started using ChatGPT and everything. The teachers are one who are afraid. They're not so well versed and they have the resistance. Ethical considerations. I think that's the major problem. As I said, that ethics, Karuna talked about it. But what we should use, should we disclose it? As a journal, I'm talking about, I'm on the editorial board of medical education. For last 2-3 years, we are all talking about in our editorial board about how do we bring ethicality in medical education journals and how people should really expose it and replicating human and emotional behavioral responses. So if you look at the literature, impact of small group virtual patient simulator training on perceptions of individual learning process and curricular integration. This was a multi-cohort study published in BMC Education fairly recently. And what it says that perception of individual learning processes and curricular integration improved after exposure to small group VPS training. And this is accessible, low risk educational strategy. And at least they are very positive about it. So we are all in a phase of excitement, though we don't know how valid it will be there and how long-term we'll use it. What will be the real lore of this into our day-to-day teaching? But we need to explore it, really find out how it is, and then adopt some part of it where we find there are difficult cases, non-accessible cases, some problems we want to face. We can definitely use this technology for them. Now, in Indian context, too many patients in OPD in a government hospital. Do we really need all this? Maybe it's your own choice. If you feel you can use part of it, not necessarily to adopt everything. Role in rural healthcare education where live patient exposure is limited. There are so many medical colleges in India where there are no patients. I go there and many times I find their OPDs are empty. Adopting virtual patient scenarios to reflect India's healthcare challenges like infectious diseases, chronic conditions, and cost consideration, scalability for widespread adoption. I know we all are, many times I see in our own practice, we do Indian Jugaad. Jugaad is again our word, where we now try to work on around it rather than going through it. And I'm sure we'll do this. So what is future of virtual patients? Advances in realism. We need to have now emotional and intelligence conversational AI, which are coming up. I must tell you, emotions are coming with AI. Integration with robotic and haptic technologies. I showed you how I use robot for dissection. Expansion into interdisciplinary training like nursing and physiotherapy. The team training is best taught with the crew management AI. You know, something like that showed. Like when you are trying to resuscitate in an ICU or in a military drill. This is where the AI has definitely a role. Use of telemedicine. I'll finish it in a minute. Okay. And scalability and scalability. So this is something which has come up in a new way. A virtual patient with your angio suits, vascular patient link, all these are in India available, and data privacy bias, which is already there. Ethical guidelines, which are very important. A lot of ethical guidelines come. My granddaughter, who is in a 6th standard, came to me and asked me that she already has a lesson on ethics in AI. Imagine this is already in their studies. So what is future now? I'm sure we are going to have. What happened? This is not working. Can somebody just, the driverless taxis. Next slide. Can we just push it? Don't bother. Yes, AI hospital in China has already come, world's first AI. And this last one, which I showed you, was the AI health communicator like Sara, which has been created by the AIG hospitals. And I think these are something which are important. So conclude, I would like to say, AI in simulation offers unprecedented accuracy. There are AI and computing power continue to advance simulations and expected to become even more realistic, predictive, and integral to high stakes of training environments. AI has come to stay. AI has potential to improve surgical outcomes. AI will not replace surgeons, but will augment their performance and embrace technology while staying human. That's the only last message I want to give you. So everything will come, but the humanity, the humanness, that is where we need to score over the AI. And that is the line, and that's where we should work on this. So thank you so much. I'm sure I'll take some questions.
Thank you so much, sir. We are humbled to have had this talk from you. In fact, having touched upon the various elements of medical education, even to the point of using AI for formative assessment, we would be able to take just one question. I'm sorry, because of paucity of time. Yes,
sir. Good afternoon, sir. Sir, it was an absolute privilege to hear you, the exhaustive details with which you went into clearing our concepts. Thank you so much, sir. The question that you raised and the question a lady raised a little earlier about the haptic feedback, I just wanted to inform you that here in the Department of Surgery, we've procured the Symbionics lab simulators. So that
there is some AI element in that.
Yes, sir. So if you try and cut the cystic duct, your hand reverberates and it gives you a jerk back. So probably we are making strides on that. We'll be more than happy to show you, sir, in case.
Sure.
Thank you so much, sir.
Thank you, Carlos Alpha. So please, sir.
So very well spoken, sir. As a medical educator in a private medical college where I work, do you have a solution for the paucity of patients? Do you think you can implement virtual patient as a universal panacea?
I think there has been, people have been using it all over.
They are using, but still, you know, the paucity of patients. I worked in government medical colleges. So this paucity of patients, and we try to put the wolf's clothing on a sheep and try to say that we have patients. But this is the real problem here. We need to train people.
See, I must tell you very clearly, what we are going through is a chaos in medical education in India. We have increased the number of seats without increasing the infrastructure. The same institution has now 24 students where there were 8 students of PG. And now you are finding you don't have enough work for them. Now, this is where I feel simulation and their skill upliftment is going to be of a great help to them. You know, so skill labs is definitely there. Virtual patients for OPDs where people don't get to see uncommon cases, complex cases. I think this is where you can definitely use these patients. As I said, it should be supplementary rather than completely changing.
Thank you so much, sir. In fact, that would come to end of this session. It's my singular honor to present Momento to Sir. I would invite him on the stage for the same.
May I now request Major General Manas Chatterjee, Vishisht Seva Medal, to kindly felicitate our chairperson, Colonel C.S. Makhani.
I now invite all delegates to join us for lunch at Madhavan Lawns at Officers Mess.
Post-lunch, we have an interesting session on generative AI. While the 60% of the presentation is formatted, 40% is impromptu. You will experience real-time working on generative AI. We request you all to be present for this post-lunch session at 2 o'clock.
A gentle reminder for today's banquet dinner at Officers Mess at 2000 hours. All delegates are cordially invited to join us for the banquet dinner today. We will resume at 1400 hours. You're requested to be seated 5 minutes prior to the session commencement.